no, so to speak. It's on COVID-19. What else are we going to talk about? No, so this pandemic that has been gripping the world. No, that's why I call it a pandemic for the past few months and from the start of the year. And we'd like to talk about concepts. No, what do we know about it? What are the concerns that we have, and what are the controversies that are enveloped in this pandemic? Um, before I turned on my Zoom and logged in, I checked the what's that website? Yung Johns Hopkins website, and they're the ones really monitoring, no. So if you look at their website, you'll see dati ang Pilipinas, no, malayong malayo. Now we're at the 22nd, no. I just checked right now. We're number 22 from US is number 1, then followed by Brazil and every. Then we're number 22. Naungusan na natin ang Indonesia. Bangladesh na lang ang matinding-matindi rin, no? Very far ahead. I think 300,000. But you'd wonder, no? You really wonder why there's Laos, there's Burma, there's Cambodia, there's Vietnam. Supposedly, these are poorer countries than us, no? Yung Vietnam nga, maunahan na tayo. But they have less than 1,000 confirmed COVID cases. Why is that? So maybe that's part of the controversy that we're going to talk about. Perhaps Dr. Castellano, no. So and in the past weeks or so, few weeks, we've really had a surge of sorts, no, from just dating at 20,000, 40,000 ang pinag-usapan. Now we're in the hundreds of thousands. So what happened there? So with this conference, I'm not saying we're going to answer this, no, Dr. Pasayan, Dr. Castellano, Dr. Rico, Lodronio. I'm not saying we're going to find the answer, but at least we discuss these things, and at least for our community and for our Saint Cabrini family, we'd like to be enlightened on this COVID-19. Okay? And so with that, I welcome you again to this very first virtual conference that St. Francis Cabrini Medical Center has prepared. Okay? And Christine, can we have I'd like to introduce now our resource speakers and experts. We have Dr. Mark Joseph Castellano. He's currently a medical specialist 3 and a pediatric infectious disease consultant at the Research Institute of Tropical Medicine, RITM. He completed his college degrees, BS Bio, double degree, BS Bio and BS General Science at the Del Salle University with Latin honors. As a scholar, he was also a scholar at St. Luke's College of Medicine and had his residency in the same institution in pediatrics. And then he took his pediatric infectious disease fellowship training at the Philippine Children's Medical Center. And now he's a member and diplomate of the Philippine Pediatric Society and the Pediatric Infectious Disease Society of the Philippines as well. Dr. Castellano is, aside from being affiliated with RITM, he's also active Pedia infectious consultant, disease consultant at various medical centers in Laguna. Marky, I added Batangas because you're already affiliated with St. Francis Cabrini. So you have to update that. Yeah, yes, thank you. Mark Joseph, no, Castellano, Dr. Mark Joseph. Moving on. We also have as a reactor to give his insights and to share his expertise in the imaging front. Is Dr. Rico Lodronio. He's a graduate of the UERMMC College of Medicine, and he had his radiology residency training at the University of Perpetual Health Medical Center. He is a fellow of the following specialty societies: the Philippine College of Radiology, the CT MRI Society of the Philippines, and the Ultrasound Society of the Philippines. And he's the residency training officer of radiology at the Perpetual Medical Center, both in Las Piñas and in Binyan, and as well as a CT and MRI Fellowship Training Officer in Perpetual Medical Center in Las Piñas. So welcome, give a virtual welcome to Dr. Rico Lodronio. All right. Okay. Next, Christine. And last but not the least is our own, all of them are affiliated with us. Our facilitator and moderator for this conference is Dr. Mark Kristoffer Pasayan. Okay. He's a diplomate and fellow of the Philippine Society for Microbiology and Infectious Diseases. He's also a fellow of the Philippine College of Physicians. He is an author. He has written lots of researches, but his latest is published at the Lancet, which is about conditional economic incentives to improve HIV prevention. He had a number of trainings abroad. One is at Cornell Medical College, New York, and others in Sendai, Japan, and in Taiwan, Center for Disease Control in Tainan, Taiwan. And he's also currently affiliated with the RITM, and he's also very active in the Infectious Disease Fellowship Training Program. And with St. Francis Cabrini and other hospitals in the region, he is our expert and member of the Infection Control Committee of our hospital. Ladies and gentlemen, please give a virtual welcome to Dr. Mark Kristoffer Pasayan, our moderator and facilitator. With that, I will turn you over to Dr. Pasayan to formally start the conference proper.
Thank you, Dr. Galido, and magandang hapon po sa kanilang lahat. And welcome again to the first ever COVID-19 webinar for St. Francis Cabrini. And I'd like to welcome everyone, especially our frontliners who is logging right now. But first, may I request to mute your microphone? May I request the host? I'm no longer the host. May I request the host to mute muna yung microphone ng ating participants? Yeah.
Doc,
okay.
Host na po kayo, Doc.
Okay, I'm now the host.
Rinig daw ako sa Zoom.
Yes. Yes, Karen. Nanditinig ka. Anyway, going back again, welcome, and we're happy to see 71 participants logged in this webinar, and we hope that more participants will log in the next coming minutes. Just a few house rules before we start the ball rolling. Number one, like what I said, please maintain your microphone on a mute mode while our speakers are delivering their lectures. And if you could also stop the video just to prevent interruption of the webinar. Now, there will be a question and answer and an open forum at the end of the two lectures. If you have any question, you may ask them live after the two lectures, or you may use the chat box. Just type in your question and we will address that during the open forum later. Now, without further ado, I'd like to call in our first speaker. Our first speaker is a pediatric infectious disease specialist, and he's going to update us on the current status and management of COVID-19. Please give I may ask everyone to give him a round of applause, virtual round of applause, Dr. Mark Joseph Castellano.
Hi, Doc. Mark, thank you for the introduction. Thank you, Dr. Malen, for the introduction. So, good evening to everyone. Tonight, I will be discussing some concepts, concerns, and controversies with regards to COVID-19. So, I would like to share my screen. Can you see the presentation?
Okay, Marky.
Okay, so So presently, our global situation with regards to COVID-19, the confirmed cases globally is 18,902,000 as of today. And of that, we have already 709 deaths. This is the picture of WHO coronavirus dashboard, wherein for today, we have already 278 new cases, 1,000 new cases. And of this, the region which has the most number of confirmed cases is still the Americas, followed by Europe, Southeast Asia, Eastern Mediterranean, Africa, and Western Pacific. You can see here in the figure that the cumulative cases are increasing starting from January up until August. And with regards to the mortality or death, the Americas is still the leading region with 376,000 deaths. So the current status of COVID-19 in the Philippines, as of today, they have this publication which is a situationer. It's named as Beat COVID-19 Today, a Philippine situationer. And as of yesterday, the latest issue was published yesterday. We have approximately 119 cases, 1,000 cases of COVID-19. And of this, 66,000 have recovered, and mortality rate, or death have increased to 2,115. The breakdown of active cases, we have 7.8% are asymptomatic, and majority of these cases are mild. So 91% are mild, and then 398 are belong to the severe class, and 277 in the critical category. So we have here the table of the top regions by active cases, wherein NCR has 28,627 active cases, and then followed by the Calabar zone. So we have approximately 8,400 active cases presently. And then new cases as of yesterday, for the NCR, we have 2,041, and the Calabar zone has 561 cases. So Laguna and Batangas, belonging to this region, has the second most number of cases. With regards to the top C countries by confirmed cases, for the past few days, we have been on the second place. However, as of yesterday and as of today, we are already in the top place. So with 119,000, Indonesia with 118,000, followed by Singapore, and so on. With regards to the number of beds occupied, as of August 6, only 51% have been occupied. However, in NCR and Laguna and Batangas, I think that this is not reflective of the current status of our hospital beds, ICU, because every time there's a patient to be admitted, most hospitals are already full. So as of August 6, 51% of the hospital beds were occupied, 54% of the ICU beds occupied, 53% of the ward beds, and 50% of the isolation beds. However, for the NCR, 73% of the beds are occupied, isolation beds 76%, 86% for the ward, and 46% of the ventilators are in use. For the Calabar zone, we have 67% beds occupied, with isolation bed at 60%, ward beds at 67%, and ventilators used are only at 31%. So we also have here the figure for the daily testing output nationwide. As of today, we have already increasing number of laboratories testing PCR nationwide. Approximately about 90 plus laboratories are now accredited for testing of PCR. And the daily positivity rate is approximately between 10 to 15%. For example, if presently we have 100,000 cases, approximately 10 to 15,000 of them are positive. This figure shows the status of our laboratory licensing in the Philippines as of August 4, and 75 laboratories are now capable of doing PCR, 24 are capable of doing gene expert, and 87 laboratories are still applying for license. However, of these 87, 85% are already in the stage 3 and 4, which in a few days or a few weeks, they will be able to get their license to operate already. Now, as of yesterday, there has been 53,000 cases of active cases, and there has been an increase of 3,300 confirmed cases done by 89 of the 99 accredited laboratories. Of these active cases, 91% are mild, and as of yesterday, we now have a total of 122,754 cases. And among the total recoveries, it increased to 66,000, and deaths at 2,100. Now, we now go to the diagnosis of coronavirus. So we know that COVID-19 can be considered in any patient with compatible symptoms, such as having fever or respiratory tract symptoms. Those who have reside or have traveled to areas with community transmission, those with recent close contact, those with severe respiratory illness without clear identified etiology. Other consistent symptoms may include myalgia, diarrhea, smell or taste disturbances, which is now becoming more common symptom of COVID-19 in certain patients. COVID-19 has no specific sign or symptom that can reliably distinguish it from other viral illnesses. And the following signs and symptoms may warrant higher level of clinical suspicion if the patient will have anosmia or myalgia, and dyspnea after several days of symptoms. It has been found out that anosmia and myalgia are highly associated with a positive PCR test for COVID-19. If possible, all patients with symptoms of COVID-19 should undergo testing for SARS-CoV-2. And those population or group of individuals who were suggested to be prioritized include the following: those hospitalized patients, those symptomatic healthcare workers, those symptomatic first responders like our policemen, those who are our frontliners like the nurses, also the med techs, those who work or reside in congregate settings like in the convents, in the jails, in nursing homes, and those with risk factors for severe disease. Later on, I will discuss those individuals who are at risk for having severe disease. From the IDSA guideline, we have 4 classes or categories to be prioritized for testing for COVID-19. For the first or the high priority, we have the critically ill patients receiving ICU level care, as well as those individual with fever or features of a lower respiratory tract and close contact of a confirmed case, those who are immunosuppressed or immunocompromised with AIDS, HIV, or those undergoing chemotherapy, and those individuals who are critical to the pandemic response, including us, the healthcare workers, the public health officials, and other essential leaders. The second priority would be those hospitalized patients, those who are admitted, and with fever, unexplained fever, and features of lower respiratory tract disease, or those with pneumonia. The third priority would be those outpatients who meet the criteria for influenza testing with comorbid conditions, such as those with diabetes mellitus, especially those who are having uncontrolled diabetes mellitus, those with COPD, those with congestive heart failure, and those with immunocompromising conditions. And the last priority would be those individuals who are asymptomatic for community surveillance as directed by the public health or infectious disease authorities. Testing of asymptomatic individuals is important for public health infection or control processes. And with regards to testing these individuals who are exposed to a confirmed case, These individuals should include those individuals at risk for severe disease living in select areas such as the correction and detection facilities or long-term care institutions. Those patients at areas with high prevalence, example, those living in areas with 10% positive rate for PCR, those who are going for surgery or those who will undergo aerosol generating procedures, they are also recommended to test for COVID-19. And those who will start immunosuppressive treatment, like for example, starting chemotherapy, or those patients who will undergo transplantation. And lastly, we also do testing for contact tracing for close contact of a confirmed case. With regards to testing of individuals who are exposed to a confirmed case, the optimal time for COVID-19 testing is uncertain. However, 5 to 10 days post-exposure, so it's 5 to 10 days 5 to 7 days post-exposure is recommended based on the average incubation period. Even if a close and high-risk contact has a negative viral test following exposure, quarantine is still suggested for 14 days. For the diagnosis of COVID-19, presently, we use the PCR. It is a type of a nucleic acid amplification testing which detect the SARS-CoV-2 RNA, and it's the preferred test for COVID-19 presently. A single negative NAAT result is sufficient to exclude COVID-19, especially in symptomatic individuals. If initial testing is negative but suspicion remains high, testing may be repeated after 24 to 48 hours after the first test. And for PCR, it is recommended that we use the upper respiratory tract samples, and CDC recommends collection of one of the following: nasopharyngeal swab, nasal swab, nasal or nasopharyngeal aspirate, and oropharyngeal swab. However, it was noted that oropharyngeal specimens have lower sensitivity compared with nasal or nasopharyngeal specimens. Furthermore, there is limited data on the accuracy of the saliva specimens, which is used for the oropharyngeal swab. The IDSA suggests NPS or nasal swab rather than OPS for our PCR for COVID-19. So in hospitals, if you are given the choice whether to do a NPS or OPS, it's better if we can do the NPS, but it would be better if we are going to do both. For lower respiratory tract specimens, it can also be used for PCR testing. However, these specimens are reserved for those with negative initial test using the upper respiratory tract specimens, but still we are highly suspecting our patients to have COVID-19. Expectorated sputum is not recommended since patients with suspected COVID-19, induction is not recommended with the risk of aerosolization. Tracheal aspirate or bronchoalveolar lavage is recommended for those who are intubated. Most NAAT have not yet received authorization for lower respiratory sample. Thus, laboratories need to validate these specimen types before we can use them for confirmation. The accuracy of PCR in detecting SARS-CoV-2 virus are higher and more frequently detected in nasal specimens, as I previously mentioned, compared with oral specimens. And the relative sensitivity of saliva specimen compared with nasopharyngeal specimen is only 85%. NAAT sensitivity also depends on the type and quality of specimen obtained, whether OPS or NPS, and the duration of illness at the time of testing, which means that depending on the duration or stage of illness, the accuracy of your PCR also changes. And according to a study, the best time to get the PCR or the best time to have PCR to have the highest sensitivity will be at 1 to 3 days after symptom onset. The SARS-CoV-2 PCR is highly specific. There is false positivity. The false positivity rate is rare, and the false negativity rate is only 5 to 40%. Lower respiratory tract specimens was noted to have higher viral load. Those for bronchoalveolar lavage or tracheal aspirate, they have higher viral load. And in a study, they detected that bronchoalveolar lavage will be positive 95% of the time. For sputum, it's 72%, and for the OPS, it's only 32%. The false negative rates of PCR based on the time of exposure, it's 100% on the day of exposure. So if you're going to test a person who is exposed to a COVID confirmed case, the false negative rate is 100% on the day of exposure. So, and then it's 38%. It has 38% false negative rate on day 5 of exposure and 20% on day 8 of exposure. The false negative rates of PCR based on day of illness, if you get it on the first 3 days of illness, the false negative rate is only less than 10%. So it's the best time to get the PCR on the first to third day of symptom onset. However, at day 6 of illness, the false positive rate increases to more than 20%, and at 14 day of illness, the false negativity rate increases to 50%. The PSMID recommends the following. All symptomatic individuals suspected of having COVID-19 patients should undergo SARS-CoV-2 PCR assay testing to diagnose COVID-19. The nasopharyngeal rather than the OPS or the oropharyngeal specimen are preferred for SARS-CoV-2 testing. And specimens from sputum, ET aspirate, and bronchoalveolar lavage may also be used if the initial upper respiratory tract specimen are negative and we are still considering SARS-CoV-2 for our patients. How about those patients with persistent or recurrent positive PCR? So the virus can be detected in the PCR for weeks. The positivity of the PCR testing starts to decline by third week until it becomes undetectable. Prolonged or recurrent viral RNA detection in the PCR does not necessarily indicate prolonged infectiousness. And infectious virus isolation has been rarely documented in patients with symptom resolution and more than 9 days has elapsed from the onset of illness. In one study, 90 RT-PCR SARS-CoV positive samples were incubated on vero cells, and only 26 of these samples demonstrated viral growth. In their study, they noted that there was no growth in samples with symptom to onset test for more than 8 days. So they concluded that SARS-CoV-2 or the virus in vero cell, the infectivity was only observed for symptoms in less than 8 days. The study also recommends to conduct further trials so that of larger size so that their initial findings would be supported. For those with recurrent positive SARS-CoV-2 PCR, the interpretation is uncertain. However, some studies suggested that this does not represent reinfection. The knowledge on protective immunity to SARS-CoV-2 is still incomplete, and early reinfection has not been ruled out and is still a possibility. From the CDC, they consider that reinfection may be possible in patients with positive PCR if there is more than 6 to 8 weeks or 2 months interval from the initial infection. For example, the patient had a positive PCR last March, and then the patient already had 2 negative PCRs. However, come July, come August, when the patient became symptomatic again and was tested for PCR, it became positive, then reinfection is highly likely. After PCR, we now go to serology. Serology detects antibodies to SARS-CoV-2 in the blood. So we use blood as sampling. And serology or the antibody testing may identify some patient with current infection, especially those who will present later in the course of the disease. And usually, the antibodies will start to increase after 1 week. And from the CDC, it's from the 9th to 14th day of illness after onset. Antibody testing is less reactive in the first days of illness onset, and it has no or very limited utility for diagnosis in acute setting. In a systematic review of 11 studies, they had 2,660 samples on a lateral flow immunoassay. It showed only a sensitivity of 66%. So there's really a large number of percentage, approximately 34%, will have false negative results from the lateral immunoassay, those rapid antibody tests that we are using in hospitals, in companies. So usage of this antibody testing should be given with caution. In a systematic review of 38 studies, IgM and IgG detection from the symptom onset, they note the increase in IgM only of 23% after 1 week. IgG increased by 30%. After the second week, it's 58% and 66% for IgG. And after week 3, 75% and 88% for IgG. Current evidence does not support the continued use of existing point-of-care serological tests for COVID-19 because they have an increase or a high level of false negative, or the sensitivity is only at 66%. Studies that determine the specificity of serologic tests in the large population is limited presently. And using our antibody tests, there is risks of having a false positive test or a false negative test. False positive risks include IgM and potential cross-reactivity with common cold coronaviruses. And false negative risk if performed early in the course of this disease, especially those with mild course. So if we are going to use the antibody test for those who are asymptomatic, the false negative risk is higher or is significantly elevated. So what's now the use of antibody testing or serology? So from the IDSA guideline, the potential uses of our serology or our rapid antibody test includes the following. Number 1, detection of PCR negative cases, especially in the late course of the disease. Because in the late course of the disease, the PCR may be negative already. But if we are still highly suspecting that the patient is having COVID-19 complications or the course is still compatible to COVID-19, then we may do the antibody testing or the serology. Serology can also be used to identify convalescent plasma donors, which can aid other COVID-19 positive patients who are critically ill. It can also be used for epidemiologic studies of disease prevalence and verification of vaccine response. Serology may be better suited for public health surveillance and vaccine development than for diagnosis. So from the PSMID recommendations, rapid point-of-care lateral flow immunoassay antibody tests are not recommended as standalone tests for COVID-19. It is not recommended for mass testing. It is not recommended for clearance for work of asymptomatic people due to low sensitivity and high false negative rates. And laboratory-based immunoassays such as chemiluminescence assay, the CLIA, and the enzyme-linked immunoabsorbent assay, the ELISA, are the preferred tests for antibody determination. And this is best done on the 3rd week from the onset of symptoms wherein they have the highest positivity rate. So moving on, we now go to the antigen tests. This is a relatively new mode of testing for COVID-19. Antigen test detects fragment of proteins found or on within the SARS-CoV-2 virus. And these antigen tests are easy to use and may be performed at the point of care. So this antigen test can somehow be used to confirm or to detect whether a patient has COVID-19 rather than the antibody tests. And the antigen tests are highly specific. However, they are less sensitive than PCR and they have higher false negative results. And a negative antigen test does not rule out SARS-CoV-2 infection. In addition, the antigen test only detect the virus who are actively replicating. Therefore, this test can be used to identify acute or early infection. So if the virus is not actively replicating, then this antigen test will not be positive. The rapid antigen test can also be potentially used as an alternative to PCR for symptomatic patients during the first week of illness. And a negative antigen test result may be confirmed by PCR if the clinical suspicion for COVID-19 is still high for our patients. The WHO also cautioned against the use of rapid tests based on antigen testing or antibody detection because of concerns of false positive or false negative results. and WHO does not currently recommend the use of this antibody or antigen test for patient care. So presently, we still only have the PCR to confirm whether our patients have COVID-19 or not. And the research into their performance and potential diagnostic utility is highly encouraged as of the moment. For the viral culture, it's not really recommended as of this time because cultivating SARS-CoV-2 in laboratories are dangerous with potential spread and risking our healthcare workers, the laboratory technicians. And for safety reasons, it is not done. The viral culture is only reserved for research purposes only. So aside from testing COVID-19 in respiratory samples, we also need to test for influenza or RSV if they are circulating in the community. It is reasonable to test these viruses when testing for SARS-CoV-2 as this could have management implications. Detection of another viral or bacterial pathogen does not automatically rule out SARS-CoV-2. For example, when you cultured an ET aspirate and you grew a bacterial pathogen, it does not mean that SARS-CoV-2 is already ruled out because the only way or the only objective way that you can rule out SARS-CoV-2 or COVID-19 is by testing through PCR test. So co-infection with SARS-CoV-2 and other respiratory pathogens have been reported with variable frequencies. Furthermore, for diagnosis, ancillary tests are recommended when COVID-19 is suspected to guide our management. So this includes CBC, metabolic panel, markers, so that this can guide us in the management of our patients, especially those who are critically ill or severe. For the management of COVID-19, outpatient care is appropriate for most patients with COVID-19 since 80% will have mild illness and these patients will not warrant medical intervention or hospitalization. Remote management can be also advised since these are preferred for majority of our patients. It can prevent unnecessary face-to-face consult. It can also lessen the exposure of patient to other patients and healthcare worker to the virus. However, if patients will have respiratory distress, urgent in-person evaluation will be needed. In addition to management of COVID-19, we also need to assess the risk for severe disease. And the following individuals are at risk for severe disease: those with older age, those residing in nursing homes, those with chronic medical conditions, those who are immunocompromised with cardiovascular or cerebrovascular disease, those with neurologic or hematologic disorders, those with hypertension and uncontrolled diabetes mellitus, those who are obese, and those who are pregnant. COVID-19 in children, majority of the pediatric population will have mild disease. In a study including 2,135 patients, 90% were noted to have asymptomatic, mild, or moderate disease. And infants and children with underlying medical conditions, such as having renal problem, those with primary immunodeficiency, are at risk for severe disease, and in these children will warrant closer monitoring. There is one condition in children known as multisystemic inflammatory syndrome in children secondary to COVID-19. This is a rare and serious condition associated with current or recent COVID-19. When we say recent, some patients will have the manifestations of this MIS-C approximately 1 to 2 weeks after having COVID-19. For hospitalized patients, we need to evaluate features for associated with severe illness, like elevated D-dimer, CRP, LDH, troponin, ferritin, and CPK. We also need to identify organ dysfunction or comorbidities that can complicate therapy. For example, for those with chronic viral hepatitis, it could affect interpretation of transaminase elevations and exacerbate hepatotoxicity of certain therapies. For those with HIV infection may change the assessment of patients' risk for deterioration and would warrant initiation of antiretroviral therapy. For hospitalized patients, chest radiograph or chest X-ray is sufficient for initial evaluation. However, chest CT scan is reserved for conditions that may change clinical management. There are some characteristics findings which may be seen for COVID-19, such as ground glass opacification with or without consolidation, and these findings may be also consistent with a viral pneumonia. One drawback of radiologic finding is that they cannot reliably distinguish COVID-19 from other causes of viral pneumonia. So this table was uh, lifted from the PSMID recommendations, wherein patients with mild classification for COVID-19, those who have fever, cough, fatigue, anorexia, and those without signs of pneumonia or hypoxia, the management would just be home isolation for 14 days. And if elderly or with unstable or uncontrolled comorbid conditions, they need to be admitted. And empiric antibiotics are not needed in mild classification without signs of pneumonia or hypoxia. For those with moderate classification of COVID-19, these are patients with signs of non-severe pneumonia. And these patients are admitted to a designated room or unit in hospital setting. For those who are severe, these are patients with cough, dyspnea, and SpO2 of less than 92% on room air. So the treatment for this group of patients will be individualized. And for those who are critical, we consider COVID-19 ARDS, and the management will also be individualized, case-to-case basis per patient. The treatment for bacterial pneumonia in COVID-19, the antibiotics, they are not really routinely recommended for those with confirmed COVID-19. Bacterial superinfection is not a prominent feature of COVID-19. And however, clinical features of COVID-19 are difficult to distinguish from bacterial pneumonia. Thus, empiric antibiotic for community-acquired pneumonia is justifiable when the diagnosis is uncertain. Because, for example, if there is clinical suspicion of bacterial pneumonia, example, new fever after defervescence or with new consolidation on chest imaging, then empiric antibiotics are justifiable. Other concerns and issues. For the prevention and evaluation of venous thromboembolism, there is high rate of thromboembolic complications among patients with COVID-19, and thus prophylaxis for all hospitalized patients with COVID-19 is suggested. The dosing and selection of the therapy depends on the condition of each patient. NSAID use. For fever, we still use acetaminophen as the preferred antipyretic agent. And if NSAID are needed, we use the lowest effective dose. Initially, there has been studies before which states that the use of NSAIDs will lead to a more severe course for COVID-19. However, as the current situation now, there is no sufficient clinical data to prove this. And thus, the recommendation is that we may use NSAIDs when clinically indicated. The European Medicines Agency, WHO, as well as the United National Institutes for Health, treatment guidelines do not recommend NSAIDs to be avoided when clinically indicated. So kung kailangan gamitin, we can use NSAIDs. How about inhaled medications? Inhaled medications are recommended to be given through a metered dose inhaler or MDI. And we avoid nebulization to avoid risk of aerosolization. If nebulization is really needed, we need to do the proper precautions, such as do them in an isolation room. The healthcare worker will wear proper PPE. We need to limit the number of personnel during nebulization, as well as after nebulization of patients with COVID-19 suspect or confirmed, we need to avoid entering the room for at least 2 to 3 hours after nebulization. How about for ACE inhibitors or ARBs? If the patient is using ACE inhibitors or ARBs, just continue treatment with them. There was initial speculation that this risk increased the risk for adverse outcome. However, this is not supported by various studies. And ARBs has been initially proposed also to have protective effects. However, no trial evidence was done to document this hypothesis. For the statins, we just also continue treatment for those patients receiving statins. Initially, there was concern of hepatotoxicity from statins. However, most evidence now recommends that liver injury from statin is uncommon, and furthermore, statin inhibition of the MYD88 levels, which causes marked inflammation, might have some benefit. However, more data are needed to verify this claim. How about dexamethasone? Low-dose dexamethasone is recommended for severe COVID-19. And for adults, it's 6 milligram daily for 10 days until discharge, and which was used in a clinical trial. Of the 6,425 patients in a preliminary report, there was note of 17% total reduction in the 28-day mortality. Furthermore, there is 36% reduction for those on MEC vent or ECMO and 80% reduction for those oxygen requiring patient. However, dexamethasone was only noted to have some benefits in severe or critically ill patients with COVID-19, and they are not used for prevention or treatment of mild to moderate COVID-19. And furthermore, there is no benefit seen among patients not requiring oxygen when given dexamethasone. Now we go to remdesivir, which is a nucleotide analog which has activity against SARS-CoV-2. It is used for children and adults with severe COVID-19, just like your dexamethasone, especially those with SpO2 less than 94%, those requiring MEC vent, ECMO, and the adult dose is usually 200 milligrams. And then the duration of treatment will usually range from 5 to 10 days, depending on the patient. So it's individual case-to-case basis. If there's no improvement on day 5, then we can extend the treatment up to day 10. And especially day 10 is recommended for those who are on MEC vent and those undergoing ECMO. In their study, they noted that remdesivir reduces the time for recovery. In the remdesivir trials, approximately 1,100 patients, 89 of them with severe disease and 26% on MEC vent or ECMO, they noted faster recovery, which was the outcome were discharged from hospital and discontinuation of the O2 support. So from their study, there was faster recovery of 11 days versus 15 days from the placebo. So there's a difference of 4 days improvement in the recovery time. However, in one study, they included 237 patients in China with severe pneumonia, and they did not see any statistical significance with regards to time of clinical improvement when compared with placebo. And they also noted that there's no difference in time of viral clearance or mortality outcome. However, comparing these two, since this has a larger population inclusion in the trial, then some studies now recommends remdesivir for treatment of COVID-19. We now go to precautions in using remdesivir. In patients with elevated alanine aminotransferase more than 5 times the upper limit of normal, they are not encouraged to use the remdesivir. And as well as for those patients with estimated GFR of less than 30, unless the benefits outweighs the potential risk. Remdesivir are also not used with hydrochloroquine as well as chloroquine, and among the reported side effects include nausea, vomiting, anemia, and hypoglycemia. Convalescent plasma is an investigational therapy for severe or life-threatening COVID-19, and it may provide clinical benefit when given early in the course of the disease. From 103 patients from China with tachypnea, hypoxia, MEC vent, so these are the severe or critically ill patients, there was improved rate of nasopharyngeal viral clearance at 72 hours. However, there was no difference in the overall rate of improvement or mortality. A subset with severe course had greater clinical improvement with convalescent plasma noted at 91% versus 68%. Another COVID-19 specific therapy is your tocilizumab, which is an IL-6 pathway inhibitor. The IL-6 pathway inhibitor, if we block the inflammatory pathway, it is noted that we prevent the disease progression. In a study or in a trial, 544 patients with severe COVID-19, the treatment with tocilizumab decreased the risk for MEC vent or death. However, it was also noted in their study that using tocilizumab was associated with increased risk for secondary infection. However, this secondary infection was not noted in some studies. Hydroxychloroquine or chloroquine was initially recommended in the early stages of this pandemic because they have found out some benefits in using these drugs. However, presently, they are not anymore recommended due to lack of clear benefit and potential toxicity. Last June 2020, the US FDA revoked the use of these drugs since the benefit no longer outweighs the risk. In a study of 4,700 patients, there was no difference in the 28-day mortality of using your hydroxychloroquine or chloroquine. And using these drugs did not decrease the length of hospital stay. Thus, the WHO and the US National Institute for Health terminated the hydroxychloroquine arm of the Solidarity trial last June. Some agents: favipiravir, which is an RNA polymerase inhibitor. In Asia, it is used for treatment of influenza. In India, treatment for mild COVID-19. They note faster viral clearance, 4 days versus 9 days. And there was also note of frequent chest radiograph improvement. However, this drug is not recommended as of this time. Other agents include interferon, which has antiviral effects and inhibits SARS-CoV-2 in vitro. Azithromycin and hydroxychloroquine are not recommended for combined use due to risk of QTc prolongation and absence of clinical benefit. The lopinavir ritonavir is an HIV drug and has in vitro activity against SARS-CoV-2 and MERS-CoV. However, latest studies noted no role or minimal role in treatment of hospitalized COVID-19. Ivermectin, which is an anti-parasitic drug, also has in vitro activity to SARS-CoV-2. However, safety issues prevents it from being used for COVID-19. Presently, the optimal approach to treatment of COVID-19 is uncertain and continuously evolving. The current trial data recommend only clinical benefit with remdesivir and mortality benefit with dexamethasone if they are used in critically ill patients. So, from the PSMID guidelines, these are the recommended dosing or dosages of certain drugs used for COVID-19. So, remdesivir, favipiravir, tocilizumab, dexa, and interferon. For children, so when do we hospitalize children? Indications for admission include severe or critical lower respiratory tract disease, non-severe COVID-19 with comorbidities, and febrile infants less than 30 days. Supportive care is given to all children, and this is the mainstay of therapy. And most children with COVID-19 will improve with supportive care, even those with severe disease. So for hospitalized children, we give oxygen, fluid and electrolytes, empiric antibiotics to cover for possible community-acquired pneumonia or healthcare-associated pneumonia. And we also need to monitor cytokine release syndrome by measuring the BP, the oxygen, and biomarkers. And we do the CRP, D-dimer, LDH, and IL-6 to monitor if there is worsening of the disease. For children, the antiviral therapy is only for selected patients since we lack data from these trials regarding treatment in children because most trials include adults. Antivirals are not needed for majority of children, and antiviral therapy should be considered only on a case-to-case basis. Antiviral therapy are also reserved for documented severe COVID-19 disease. So for children, if you're going to use remdesivir, these are the recommended dosing. And hydroxychloroquine and chloroquine, efficacy in COVID-19 in children is uncertain, as I previously discussed, and it is not anymore recommended. Lopinavir, ritonavir is not recommended in children. The glucocorticoids in children, the trial is ongoing with uncertain risks and benefits. But we can also use dexamethasone in children as well as prednisolone and methylprednisolone. Other adjunctive therapies such as immune modulators are not routinely used. And for vitamin A, there is no available data for treatment of COVID COVID-19. So for children with documented or suspected COVID-19 with mild symptoms only, then they need to be isolated at home to prevent transmission to others, monitor the clinical status, and give them symptomatic and supportive care. And this is similar to treating other respiratory or gastrointestinal symptoms. For example, if the children is having loose stools, then we replace the losses with ORS or Pedialyte or Hydrite. And then if the patient is having respiratory signs and symptoms, then maybe we can give some nebulizations, or if the patient is having nasal congestion, we can give decongestants. For the PSP recommendation as of last May, hydroxychloroquine and chloroquine are still included. However, since the latest recommendations now shy away from using this recommendation, in children, we can use the following: azithromycin, vitamin D3, and zinc sulfate as per PSP recommendations. So, other recommendations for children include the prioritization of newborn care and vaccination of children as advised by the CDC and AAP, and children more than 2 years old are advised to wear cloth mask. However, if the child is less than 2 years old, a face mask is not recommended due to risk of suffocation. Other recommendations also include to avoid play dates, to minimize the spread of disease, and an alcohol-based sanitizer is safe for use in children. There is no safety concern to lick or eat hands after sanitizer has dried, and children less than 6 years old should be supervised in using hand sanitizers because of the risk of alcohol intoxication even with little amount of liquid ingestion. Methyl alcohol is avoided, and it was also noted that isopropyl alcohol is more toxic than ethyl alcohol. So for children, it is better to use ethyl alcohol rather than isopropyl alcohol. So now we go to the vaccination status or the vaccine status of COVID-19. As of July 31 from WHO, there has been already 26 candidate vaccines in clinical evaluation. So approximately majority of them are already on the phase 2 or 3. So these are the number of vaccines in clinical evaluation. And in addition to this, there are already 139 candidate vaccines in the preclinical evaluation. So hopefully at the end of the year or early next year, we are going to have a vaccine already for COVID-19. Now we go to criteria for discontinuation of transmission based precaution and discharge. So there are two methods for discontinuation isolation or removal from isolation. No, so we have the time and symptom based strategy, which is 10 to 14 days after symptom onset plus at least 3 days without symptoms. And this is based on the WHO interim guidance. If we are going to use the test-based strategy, we are going to have, we need to have 2 consecutive negative PCR 24 hours apart to document recovery and virologic clearance. Test-based strategy for certain groups, for example, those who are immunocompromised with other comorbids, the precaution and isolation may be discontinued 10 to 14 days after symptom onset, plus at least 3 days without symptom, and a negative PCR test on day 14. So the additional requirement for certain groups would be a negative PCR on day 14 from the date of onset and symptoms. So how about the repeat testing after a positive COVID-19 test? So we now know that viral shedding of SARS-CoV-2 virus may last for weeks. And from several studies, virus is likely non-viable by day 8. And detection of viral RNA by PCR is not synonymous with an infectious virus being present. Thus, a repeat testing after a positive COVID-19 test is no longer recommended at this time, and a time or symptom-based strategy for discharge and return to work are preferred. So if we have a patient with a positive COVID-19, we can use the time or symptom-based strategy, and we don't need anymore the presence of a positive result to document recovery or clearance. How about for, so a repeat testing after an initial negative COVID-19 in a symptomatic patient. So you have a symptomatic patient, the patient tested negative. However, you still have high clinical suspicion that it is COVID-19. So you still do a repeat test. So this is a infographic from the DOH. So this is this shows the recovery and discharge criteria. So paano madedeklara na recovered na ang isang pasyente? So based on the CDC and WHO, 10 days. And then 10 days from the first day of the symptom without fever for at least 3 days, and the symptoms have already improved. So for the CDC and WHO, it's 10 days. However, here in the Philippines or from the DOH, we use 14 days. So the criteria for DOH is more strict. And for those who are symptomatic, so they can be deemed recovered or they can be discharged if they have no signs and symptoms for at least 3 days and they were able to complete 14 days isolation. And for those asymptomatic, so those who tested positive, they can be removed from isolation after 14 days from the date of their PCR test. So for example, here, when a patient can be considered recovered, if June 29 is the date of illness or specimen collection, then you just add 14 days, and July 14, the patient can now be recovered as can now be tagged as recovered based on the physician's assessment, assuming that the patient has been febrile for 3 days and does not have any symptoms for 3 days. So this is what the DOH is using right now in comparison with the CDC and WHO, which uses the 10 days duration. So how about the healthcare workers? For our nurses, for our doctors with SARS-CoV-2 infection, the test-based strategy is no longer recommended because in the majority of cases, it causes exclusion of the healthcare worker from work who continue to shed virus but are no longer infectious. So this exhausts the number of our healthcare workers if we just test them and they just become positive, knowing that approximately more than 9 to 10 days from symptom onset or from the testing, these healthcare workers or these individuals are no longer infectious or contagious. So when can we use the test-based strategy? We can use the test-based strategy to allow healthcare worker to return to work earlier for the severely immunocompromised if there is still concern that the healthcare worker is still infectious for more than 20 days. And we use the test-based strategy by having 2 consecutive negative results which were collected 24 hours apart. So this is based from the CDC. If a healthcare worker or a healthcare practitioner with mild or moderate illness and not severely immunocompromised, then they can return to work 10 days after their symptoms. So first day of the symptoms and at least 24 hours without fever, and the symptoms, cough, colds have already improved. However, for those who are asymptomatic and not severely immunocompromised, 10 days after the date of their first positive PCR test was out, then the healthcare worker can already go back to work without repeating the test. This is based from the CDC guideline. However, for those healthcare workers who had severe or critical illness and who are severely immunocompromised, the recommendation is not 10 days but 20 days. And for those healthcare workers who are severely immunocompromised, especially example those with HIV infection without proper antiviral, and 20 days have passed since the date of their first positive PCR test, they can now go back to work. So the fight for COVID-19 is not yet over, and we need to reinforce the fight, and it is our joint responsibility. So to reduce the risk of infection, we follow some procedures or protocols. Clean your hands often, you cough or sneeze in your bent elbow, avoid touching the nose, eyes, and mouth, and we avoid close contact with someone who is sick, and clean and disinfect frequently touched objects and surfaces. So this has been already discussed repeatedly, but we need to practice, not just know these steps or procedures. And COVID-19 is really biding its time and is waiting for us to let our guard down. So we need to continue our protective measures, physical distancing, hand washing, and use of masks. do what we can to stop the spread, because some people who are more vulnerable to COVID-19 might not be able to do the precautions. So in order to protect them, we need to comply with these recommendations. And we also need to be a role model to other people. Knowing is not enough, but we should be able to practice and do it all the time. So we need to avoid the 3 Cs, crowded places, such as elevators, close contact settings, and confined and enclosed spaces. So the DOH has this be the solution for COVID, no? So B stands for bawal walang mask, I isanitize ang kamay, D dumistansya ng isang metro, and A alamin ang totoong information and avoid fake news. So other things that matter, it is normal to feel fearful and anxious during this time, and talking about our feelings will lessen the distress. Working on the front line can be stressful and difficult, and talking our feelings with somebody we trust will help alleviate this stress. Viruses don't discriminate, and neither should we. And as a summary, these are the procedures or practices which will help us prevent COVID-19 spread. Washing our hands for 20 seconds, 70% alcohol for 20 seconds, avoid touching our eyes, 1 meter distance from other people, or better, 2 meters distance. Avoid touching things that many people will touch, like doorknobs, mask outside, frequently clean surfaces, disinfect regularly, and disinfect our most used things such as phone with alcohol. So we are in this together. Let us do our bit in the fight against COVID-19, and thank you for your attention.
Thank you, Dr. Marky Castellano, for that very comprehensive talk. You addressed the common issues on the current status, epidemiology, down to the current diagnostic test, and of course the management. We have 88 participants in Zoom right now, and around 70 participants in Facebook Live. So participants are coming in still, and we have some questions already in the chat box. But we will address those questions later during the open forum. I'd like to call in our second speaker now. Diagnostic imaging plays a very crucial role in the diagnosis and management of COVID-19. And in my practice, I guess I'm more eager to know the current diagnostic imaging results of the patient rather than their CBC. So I'd like to call in our radiologist, Cabrini's very own radiologist, Dr. Lodronio, to talk about the current issues on diagnostic imaging for COVID-19. Dr. Lodronio, are you there? Hold on.
There's no sound. There's no sound, Rico.
Hold on.
How about now, Doc?
Yeah.
All right, sir.
Yeah, okay, sorry. Hello, good evening to everyone who is online and watching this Zoom conference. See, Dr. Manin told me that this was a free-flowing discussion. I should have worn something more formal, and I should have shaved. But actually, this is a very good timing. Just to share, I just got my. I was on leave. I just got my RT-PCR result at 1 p.m. this afternoon, so it's negative. So thank you, Lord.
Congratulations.
So I was initially thinking, am I going to call Dr. Malen to postpone or to ask him to move the schedule? But fortunately, the result was negative. So good evening to everyone. I'll share my screen. Okay. Can everybody see my screen?
Yes, sir.
Yes.
Okay. So if we have had this lecture 2-3 months ago, for sure, during the time around late March and early April, there was a clamor for diagnostic chest imaging. I believe that even one city from the north availed of the AI, the chest CT, artificial intelligence in detecting COVID-19. But right now, the main role of chest imaging in this pandemic, in this COVID-19 pandemic, is to assess the status, the reaction, the response of the patient, as well as to see other complications. It's not for screening. It's not for trying to label this patient as this is a positive COVID-19 case. So somewhat from a somewhat primary role, the role of CT imaging or chest imaging became secondary. Siguro, one reason for this is because of the shorter time of getting the RT-PCR result. I believe before, around April, some of my colleagues or my some patients would usually get the result at least a week or sometimes 2 weeks after the swab was done. That's why there was a clamor while we're waiting for the RT-PCR result or the swab result. We want to know if this case is most likely COVID or not. That's why they would often request for a chest CT scan. So most of the text or the slide in my presentation is from RSNA. So particularly this article, the role of chest imaging in patient management during the COVID-19 pandemic. So this was a consensus statement from the Flischner Society. So they divided patients who need or who warrants imaging studies into 3 scenarios. So scenario 1 are those patients with mild symptoms consistent with COVID-19, but there's no significant resource constraints, meaning they can avail of CT, chest X-ray in their hospitals. The second scenario is those with moderate to severe symptoms, also consistent with COVID-19, also with no significant resource constraints. And the last scenario are those also with moderate to severe symptoms, but the resources are constrained, meaning most likely they don't have any CT scanners in their areas or in their hospital. Here are the following recommendations. The first recommendation here, imaging is not routinely indicated as a screening test for COVID-19 in asymptomatic individuals. So just like what Doctor said earlier, the sensitivity of COVID-19 as a screening test is quite low, and you can see imaging features typical of COVID-19 also in other viral, inflammatory, and infectious diseases. So one of the first recommendation is it should not be used as a screening test. So I think the clamor before of getting an AI or asking all patients to be scanned to have a chest CT scan was somewhat premature. The first scenario, so a patient comes in with mild symptoms or mild features consistent with COVID-19, and you have no significant resource constraints, meaning you have CT scans. So even if even without the COVID test, while waiting for the COVID test, even if you did or did not do the RT-PCR, it is not routinely recommended to do imaging study in an asymptomatic or a patient with mild symptoms. Okay? The only time that imaging would be indicated in these patients who have mild symptoms are those who will present with worsening respiratory status. So meaning if the symptoms from mild became moderate to severe, obviously they would be upgraded to scenario 2. So later we'll discuss the scenario 2. And also, the only time that one of the few times that you're going to recommend having an imaging study for the chest in a patient with mild features consistent with COVID-19 is if the patient has positive risk factors for the disease progression. So I think it was discussed by doctor earlier. So old age, I think more than 65, then patients who have uh, comorbids like diabetes, hypertension, cardiovascular diseases. So those are the cases who have mild symptoms who may warrant or who needs chest imaging studies. The next recommendation is imaging is also not indicated for patients with mild features of COVID-19 unless, I've mentioned it earlier, at risk for the disease progression. So ayan, again, more than 65, there's the presence of comorbids. Sorry. Okay. The third recommendation is imaging will be indicated for those with moderate to severe features of COVID-19, regardless of the COVID-19 result. So even if the patient would later on get their RT-PCR result of negative for viral RNA, but would still have moderate to severe symptoms, they are still required to have a chest imaging done. So what's the main reason for that? So again, we're now in scenario 2, moderate to severe features. Even if the COVID-19 test is negative, imaging is indicated, one, because of the moderate and to severe signs and symptoms, plus you want to check if there are alternative diagnosis. Meaning yung pasyente pala is complaining of DOB, is complaining of dyspnea, negative COVID result, yung pala is having pulmonary thromboembolism. So in those cases, obviously, you need to do other imaging. You need to do imaging studies, particularly your pulmonary CT angiogram with PTE protocol. So that's one reason why you still need to do imaging studies in a with the negative test. The fourth recommendation is imaging is indicated in COVID-19 with worsening respiratory status. So obviously, patient had no imaging studies prior, but is having more severe symptoms. The test was positive. You and the patient is complaining of is clinically is worsening. So in those, a CT scan is recommended. A chest CT is recommended. So scenario 2, moderate to severe features. Imaging is indicated because the patient has worsening clinical status. So the fifth recommendation, in a resource-constrained environment, so where access to CT is limited, chest radiograph may be preferred for patients with COVID-19 unless features of respiratory worsening warrant the use of CT. So again, if we're the patient has moderate to severe symptoms, we would opt to do a chest CT scan instead of a chest radiograph. But again, if we're limited, at least have a chest radiograph done for those cases. But if we have the luxury of having a CT scan in our institution, this should be done to the patient. So recommendation is CT to do, not to do CT or to do CT. So CT is not recommended as a screening for COVID-19. You don't do CT scan in asymptomatic individuals suspected of COVID-19, so asymptomatic. You don't do CT scan in patients with mild symptoms of COVID-19. And again, if there's a constraint in the resources, you opt to, instead of doing a CT, you can opt to do chest radiograph. When to do CT scan? If the patient has either mild, moderate, or severe symptoms, but have the following risk factors as mentioned by Dr. earlier. So the patient is an elderly patient and there's a presence of comorbidities like your cardiovascular diseases, diabetes, etc. And in patients with moderate to severe features of COVID-19, you can still do a CT scan or request for a CT scan even if the RT-PCR is negative, because you want to rule out other alternative diagnoses. And obviously, in patients who have worsening respiratory status, you can do your chest imaging. So I'm sure, especially for internal medicine and for our pulmonologists, there was a paper released by RSNA wherein they made a consensus statement on reporting chest CT findings related to COVID-19. So here are the following consensus statement. So in most reports right now, for patients wherein a CT scan was requested for evaluation of COVID-19, you usually four categories. It's either you see typical findings, you see indeterminate findings, atypical findings for COVID, or a normal chest CT scan. So yan dapat yung mga words na makikita nyo dapat sa dulo ng report ng radiologist when they're reporting chest CT scan. But take note that the patient, the attending physician should have requested, indicated in the request that the patient, they're considering COVID-19 for that particular patient. So obviously, we in our report, if, for example, the patient came in for chest CT to radiotherapy planning, so unless it's really obvious that it looks like COVID, we don't usually put those grading. What are the typical findings for, or CT findings for COVID-19 pneumonia? So it's bilateral, multifocal, meaning it involves more than one lobe. You see your ground glass opacities, and in some instances, you'll start to have consolidation. And itong the last two are the two more important morphologies. They usually form rounded lesions, and the typical distribution is peripheral. So if you see that in the report, bilateral, ground glass opacities with rounded morphology and in peripheral distribution, you would expect that the radiologist at the end of the report would tell you that these findings are typically seen in COVID-19 pneumonia. So Doctor also mentioned about ground glass opacity. So what are ground glass opacities? So just a short background. These are areas of increased attenuation in the lung used in CT scan. We don't use this in radiograph. So that's the reason why we, if you're really investigating or want to do an imaging study for COVID-19, a CT scan is much more superior. So with preserved bronchial and vascular markings. So though you can see typical findings of COVID-19 pneumonia in certain patients, these findings can also be seen in multiple inflammatory and infectious diseases. That's why in the report, you'll see there will be a disclaimer. These may also be seen in organizing pneumonia, in influenza pneumonia, and in some systemic or metabolic diseases. Or actually, even in drug toxicity, you can also see features typically seen in COVID-19 pneumonia. So at the end of the report, though it was mentioned typical, you'll see a disclaimer saying that this can also be seen in other inflammatory and infectious diseases. Sorry. So the next category is your indeterminate morphology. So again, you still see your ground glass opacities. So the image on top, the images on top are COVID-19 cases, and those at the bottom are from drug toxicity. So you can still see faint ground glass opacities in non-rounded morphology, and though you see the ground glass opacities, the distribution is not that typical for COVID. You see, in this particular case, you can see it in the more central portion of the lungs, and also in the peripheral aspect. So if you see ground glass opacities, but in a non-typical distribution and non-peripheral with non-rounded morphology, most likely the geologist would indicate that this is the findings are indeterminate for COVID-19. So the third category is your atypical. So the images I'm presenting are typical for pulmonary tuberculosis. So you see areas of fibrosis, you see nodularities. I haven't seen a COVID-19 case with cavities, as well as the typical finding of TB, which is a 3 in bud opacities are present. Most likely, that the radiologist or the report would indicate that the findings are atypical. Why not say negative? Because the fourth category is a negative scan, meaning there's no pneumonia, the lungs are clear, you don't see any nodules, you don't see any consolidation, you don't see any pleural effusion. So that's the fourth category, negative. That in between indeterminate and negative, that's where you put your atypical findings for COVID-19. So this was suggested by the RSNA. So dapat ito yung makikita nyong report in the chest CT if they're following the RSNA suggestion. So just give one example. Ito lang. For typical appearance, suggested reporting language is findings are imaging features of COVID-19 pneumonia. But yun nga, sa dulo, there's a disclaimer. Other processes such as influenza pneumonia, organizing pneumonia, as well as drug toxicity and connective tissue diseases can cause similar imaging pattern. So again, just like what doctor said, we don't really use CT or X-ray imaging to diagnose a case of COVID-19. We just give them possible complications, presence of possible complications, or other alternative diagnosis to the disease or to the condition of the patient. So some of you might have heard about CORADs. So CORADs is like your BIRADs sa breast. So there was a proposal in using CORAD. So somewhat the features or the CT findings are similar to the typical, atypical, indeterminate, and negative. They just added, I think, the CORAD 6, just like your BIRAD 6, wherein the lesion is already a biopsy proven malignancy. You have your CORAD 6, wherein you already have a case, known case of COVID-19 by RT-PCR. So they just simplified it. But again, not all radiologists use it. I personally don't use this, but at least if somebody asks me about CORADs, I can tell them that most likely that particular patient is a CORADs 2, a CORADs 3, CORADs 4. Okay. So what are the pros and cons of having a standardized reporting system in COVID-19? So one of the most important is, obviously, if the initial RT-PCR is negative, but once the CT was done or the imaging was done, the findings are typical of COVID-19 pneumonia. So that's a way to signal or to tell the attending physician that, Doc, I think we need to repeat the RT-PCR test. Most likely it was a false negative result, and because the findings that we see in CT is typical, I would suggest doing a repeat study. So also it is important because some clinicians might be not suspecting COVID-19 initially. So the patient came in because of a different reason, and the findings are typical for COVID-19 in pneumonia, and that's a way for us to alert or inform the attending physician that I think we need to do an RT-PCR for this particular patient. And one of the more notable cons of having this consensus reading is clinicians may feel that having COVID-19 in a report boxes them in and limits their options for patient management. The patient mukhang hindi COVID, but was sent to the imaging department for a different reason, and sa report ng radiologist, COVID-19 na namin. So medyo when he gets the report, medyo the attending physician will be parang bound or tied up na, uy, COVID-19 sinabi na ng radiologist paano kayang gagawin ko, no? So again, these are the instances wherein the communication between the reader as well as the attending physician is very important. So some, especially in our hospital in Cabrini, I have several cases wherein the pulmonologist would call me and tell me that, Doc Rico, mukhang ano yan COVID-19. So those are information that we really need while at hand, while we're reading our CT scans or chest CT scans, because we don't want to put those yung reading namin for CTs to be lahat pang COVID, no? So some, just like patients coming into because of radiotherapy planning na asymptomatic, again, we don't want to put the reading for COVID-19 in those cases. Especially pag nakita ng patient term na COVID-19, na nervous na sila. So I think that's the last slide.
Okay, thank you, Dr. Lodronio, for giving us a clearer picture of COVID-19 coming from, a radiologist. To tell you honestly, this is my first time that I've listened to a radiologist discuss diagnostic imaging for COVID-19, and thank you for that opportunity. Thank you, Cabrini, for inviting Dr. Lodronio. Now, we have 77 participants in Zoom and around 70 in the Facebook Live. We'll try to answer some of the questions that they posted in in our chat box. In the interest of time, may I request our speakers to limit their answers, short answers, and so that we can accommodate all the questions that are posted. Let's begin with the first question that I received. Actually, this is I don't know if he wants to be identified, but this was sent to me privately, so I guess it's an anonymous participant. Is asking, considering the fact, I think this is addressed to Dr. Castellano. Considering that there is a 5 to 40% false negativity rate in the RT-PCR, how many percentage of the cases do you encounter with typical COVID presentation? And do you continue to manage as COVID when the RT-PCR result turns out to be negative? Dr. Markey?
Thank you for the question, Doc Mark. So knowing that the false negative rates of PCR is 5 to 40%, in pediatric population or in the pediatric age group, the COVID-19 signs and symptoms really interlaps or overlaps with other diseases like other viral pneumonia, other viral causes of gastroenteritis. So in the pedia population, we usually encounter patients who are only febrile. So if to answer the question po, so if the patient is clinically really COVID-19, however, the PCR is negative, then it's prudent to repeat the test after 24 to 48 hours so that we can really verify if the patient is having COVID-19 or not. So while we are waiting for the second swab, then it's more prudent also to continue treating the patient as COVID-19 until the second swab or until the second PCR is out po. So in pediatric population, when we just continue the management. So if the patient is COVID suspected and then there's pneumonia, we just continue the treatment being given to them po.
And consider the patient as a probable case until proven that it's really COVID. There's another in question. This is a question. Okay. Someone asked if there is indeed reinfection. I know there are some stories that we get in Viber about colleagues who got reinfected. Is it really true? Is there really reinfection, and is the outcome and course poorer when compared to our primary infection?
With regards to the infection, the CDC has stated that we can consider reinfection after the patient has been asymptomatic or after 6 to 8 weeks have lapsed from the first infection. So there can be reinfection. With regards to the severity, is the reinfection more severe or less severe? As of now, we don't know yet because the reinfection can be severe if there is antibody-dependent enhancement, just like in dengue. So if there's antibody-dependent enhancement like in dengue, then the infection may be severe. However, if there would be some degree of cross-protectivity from the SARS-CoV-2 virus, then the reinfection might also be less severe. So until further studies have been conducted, we really don't know if the reinfection will be more severe or less severe as of the moment.
All right. So the data are still insufficient right now to come up with any conclusive information regarding that. Dr. Popotalia asked, hi ma'am, thank you for attending. If a patient was confined and is still critical on mechanical ventilation or BiPAP, which is aerosol generating at day 20 from onset of symptoms, and still COVID positive, I guess this is on RT-PCR, is the patient still infectious, Dr. Castellano?
According, Doc, to the recommendation of the CDC with regards to the termination of isolation or with regards to discontinuation of precaution, for those who are critically ill or those who have severe COVID-19, they are recommending a 20 days interval from the first day of the symptoms until the patient is asymptomatic. Now, to be more prudent, since the patient has been tested positive for COVID-19 and is still positive and is still symptomatic and is not yet clinically improving, then the best course of action is to still maintain the precautionary measures of airborne precaution so as to prevent possibility of spread to our healthcare workers and other individuals po. So we still consider the patient infectious if after 20 days still critically ill, still positive on PCR. So better po na mas on the safer side tayo rather than we consider the patient as non-infectious po.
All right. Sabi nga ng CDC, #stay protected. Dr. Malen Gilido asked, we've had patients with positive nasopharyngeal swab, but negative on ETA, both PCR, and both samples were taken on the same instance. How do you explain this? So we have had cases in Cabrini na positive ang NPS, negative ang ETA. We have also case na positive naman ang ETA, negative ang NPS. How do you explain this, Marky?
Okay, Doc. So knowing that the PCR po is highly specific, meaning if mag-positive siya, i-consider talaga natin yung possibility talaga ng COVID-19. Now, with negative result ng PCR, there are a lot of factors also to consider. Number one, if since different yung mechanism of collection ng specimen, it's possible that the ETA collected did not have adequate sample. So it did not have adequate sample or the viral particles are not sufficient for PCR replication. Pero since po nag-positive yung NPS natin, we will consider the patient as having COVID-19 because of the high specificity and especially if the patient is symptomatic and critically ill. So we're more leaning to the positivity of the sample po. And then also there are concerns also of handling. Siguro since kung pareho naman silang na obtain po, maybe there's mishandling na other specimen. So there are a lot of factors po that we can assume but hindi po natin talaga mapipinpoint kung bakit siya naging ganun. So we can just presume po of these possibilities po.
Yeah, everyone should remember that this is not a one-step process. It involves, specimen collection, inactivation, amplification, and then results, release of the result. So a lot of things could happen during those four processes. Dr. Reden Silva, our pediatrician, pediatric nephrologist, is asking for patients with sleep apnea. I don't know if may sleep apnea ba mga pediatric cases. Would you recommend stopping the use of CPAP machine due to the possibility of aerosolization? I think our concern natin, Dr. Silva, is would the patient be infectious if the patient is on CPAP or while on CPAP?
If the patient po, doc, has sleep apnea and will really need the CPAP, then I would not recommend stopping the CPAP because it's needed by the patient. So it's necessary. However, we need to, if there is a risk for aerosolization of from a procedure, then we do the necessary precautions like transferring the patient to a isolation room or to a negative pressure room, and then we also do other precautions like wearing the PPE, avoidance of entering the room for 2 to 3 hours after an aerosolizing procedure po. So continue the CPAP but do the necessary precautions po.
Okay, another question from Dr. Guido. An asymptomatic patient is scheduled for an elective surgery. Yan, mga concern yan ng mga preoperative issues sa COVID. Patient is scheduled for elective surgery, tested positive on PCR. Do we test the patient for PCR again and wait for patient to turn negative, or just wait 14 days and perform surgery without repeating testing? What's your thoughts on this? Marty.
Okay. So, my stand with regards to this po is that if the patient has initially a positive PCR but asymptomatic, we follow the recommended guidelines. So from CDC and WHO, the minimum recommended time is 10 days. So if we are going to use the 14 days, so mas sure po tayo na the patient is anymore not infectious. So for me po, I would not anymore recommend retesting and may do the deemed elective surgery po after 14 days of from that time the patient tested po.
Yeah, as long as they are elective. Now, Dr. Miranda is asking regarding the Solidarity trial. It focused on the toxicity of chloroquine simply because they have used toxic megadose or high dose of chloroquine. Why not use therapeutic dose instead?
Actually, Doc, maybe that is a good area for further research po to test the actual dosing for the normal dosing for hydrochloroquine. However, maybe because they use the higher dose because based from their review of related literature that the normal dosing of hydrochloroquine will not have much effect on the SARS-CoV-2 virus. But if that is one of the issues, then maybe we can further explore on this, and then we can do further researches for this for our residents and fellows to test whether a normal dose of hydrochloroquine can have beneficial effects for SARS-CoV-2.
I would agree on you, no? So the use of chloroquine is still experimental. It's an antiprotozoal drug, and the usage of chloroquine against COVID-19 is based on the possible mechanism of action that it can prevent the entry of the virus to human cells. But it's still, regardless, whatever the dose, it seems that it's not really working for COVID-19. Again, Dr. Miranda is asking, what is the best marker for us to see individuals who will be selectively knew that patient will be going to severe stage for purpose of using dexamethasone as early as possible? So is there a way that we can predict which patients will need dexamethasone in the future or in the next coming days once diagnosed with COVID-19?
Based on the limited studies that we have as of the present, it was only recommended that we use dexamethasone for those who are auto requiring, or for those who are on mechanical ventilation, or for those who are on ECMO. So for those who have a severe or critical course, but with regards to specific markers to say whether we can use or not the dexamethasone, maybe we can indirectly check on the ferritin, the dimer, those markers which can predict the severity. So indirectly, we can use these inflammatory markers whether or not we can use the dexamethasone for this group of patients.
Yeah. COVID-19 is very unpredictable. You'll never know what will happen in the next coming days, but I guess the crucial in our experience, a crucial day would be on day 8 to day 10. That's when everything seems to go wrong if the patient has severe or moderate to severe COVID-19. Now, I think the next question is for Dr. Lodronio. For individuals with radiologic findings suggestive of pneumonia, but clinically with adequate oxygenation at room air, no dyspnea, no dry cough, with or without fever, should we still consider COVID pneumonia? Ang hirap naman yung tanong. Sir, nasa iyo nakasalalay ang diagnosis kung saan namin ilalagay. Sa isolation ba o sa station 1?
Yeah, actually, just like what Doctor said earlier, CT scan is not really for diagnosing COVID-19. It's for the attending physician to use the CT scan findings as a measure of treatment response or signs of any complications. I'll give you an example, Doc. I have a case, normal ang CT scan. pero positive ang RT-PCR. So I cannot put in my report that uh, uh, COVID-19 is totally ruled out because the findings are negative. The findings in the CT scan are just I'm sure the main reason why we do the initial CT scan is for a baseline scan for that particular patient, and we want to see if there are complications like areas of consolidation. But again, it's very difficult to say that this case is a COVID-19 case. Another example, Doc, I have a hospital in Binyan, typical COVID-19 CT features. Sinintensyahan ko na, Doc. Findings are typically seen in COVID-19. 2 RT-PCR negative. So again, the CT findings would just guide us kung nasaan na tayo with the patient. But again, we're just dealing with pneumonia. The patient has pneumonia, typical for COVID-19, but that report doesn't say that the patient has COVID-19.
Yeah.
Just the report says that the patient has pneumonia. And at the other end of the spectrum, if the report says totally negative, there are no significant findings, it doesn't totally rule out the possibility of having COVID-19.
If I could just add another comment, sir. I've seen cases also of clinically COVID, pending RT-PCR, chest X-ray normal, but siyempre tingkati tayo COVID ba talaga to? Hindi pa chest CT scan tayo, ground glass opacity. So, doon papasok yung ano ba yung gagamitin talaga natin as initial diagnostic imaging. Would we go with just chest X-ray first, or might as well go straight to chest CT scan, and right there and then we'll see if there's really ground glass opacities or not. So most of the time we request for chest CT scan already. While waiting for the results of the RT-PCR.
Yeah, Doc. In the US naman, Doc, they don't bother doing the chest X-ray anymore. They go straight to chest CT scan. Plain lang yun. You don't need to do a contrast study for that.
Is there a additional value if we add contrast?
Unless you're thinking of an alternative diagnosis, Doc. Just like I have a case that they're thinking of pulmonary COVID-19, but also thinking of pulmonary thromboembolism and requested for a pulmonary CT. So if you're thinking of an alternative diagnosis, you can request for a contrast enhancement. Plain CT will do.
All right. Okay. Next question is from Dr. Lanting. Cabrini is a transplant hospital. So Dr. Markey, when can a previously COVID-positive patient be considered as a viable donor for kidney transplant? Will the 14-day asymptomatic period suffice, or a negative RT-PCR would be warranted?
With regards to the kidney transplant, since kidney transplantation is a complex and delicate matter po, so it involves delicate procedure and a high-risk procedure. So personally, I would still require a PCR for the patient before going into a transplant, since this is one of the special procedures that we do. There is really no recommendation yet for these kinds of people, but to be more prudent po, on the safer side, we finish the 14-day isolation and then we document the test for the negative PCR for COVID, so that wala tayong mamimiss out po. So
I think if we follow the protocol in convalescent plasma therapy, they also follow the 14-day post-recovery for a patient to donate plasma. Next question is, for our radiologist, Dr. Lodronio, when is ground glass description alongside other sorry, wala ako sa tanong. When it is ground glass description alongside other finding, why put viral etiology in your report?
Actually,
Why are you committing that it is virus and probably baka naman congestive heart failure?
actually,
Ganun ba
yeah.
yun?
So, the recommended nomenclature or consensus reading is just to guide the radiologists what to put in the report. But again, after putting the last line dun sa pinakita ko, you can put other etiologies based on the clinical features or clinical findings provided to you by the attending physician. If obviously that, I'll give you an example again, Doc. Maybe ang ibig sabihin nata ng question was, if there are other findings, you have ground glass opacities, then you have other findings. Why commit that it is viral pneumonia, right?
Correct.
So, maybe the report should state that the ground glass opacities may be indicative of pneumonia, but again, you can have secondary infection like tuberculosis. Then you put additional information, additional differential diagnosis based on the other clinical, other imaging findings you see together with the ground glass opacities. You see ground glass opacities, adjacent to it, you see 3-in-bud opacities. You put the ground glass opacities are typical of COVID-19 pneumonia or other viral pneumonia. Next line, the 3-in-bud opacities are highly suggestive of endobronchial tuberculosis. So again, you just add, it's not strict, hindi na sinabi na lahat ground glass opacities pneumonia. Even even pulmonary congestion could give you ground glass opacities. But the pattern would be different. So you have a typical pattern for COVID-19, which is peripheral and rounded. So I hope that answered the question.
So it's safe to say, sir, that the peripheral ground glass opacity is kind of specific to COVID-19.
Yeah. With rounded morphology, Doc.
Peripheral ground glass, rounded ground glass
with rounded morphology in peripheral distribution. Kasi, Doc, if you have a wedge shape na ground glass opacity, baka mamaya yung pulmonary thromboembolism na pala, no? So may specific distribution. Siya medyo rounded. But again, it's a typical finding for COVID-19 pneumonia, but you can also see this in other types of pneumonia.
Yes. Okay. So we have another question from Cabrini home account. Parang feeling kilala ko itong mga nagtatanong from the Cabrini account. We have observed several patients admitted for cardiovascular or CVA, cerebrovascular event, no comorbid factors, no symptoms suggestive of COVID, but are RT-PCR positive? Can you comment on this? Should we screen as well for COVID infection for this type of cases? Dr. Markey? Meaning, these are non-pulmonary ang presentation, MI, stroke, but there is that fear that there might be COVID co-infection. Would you recommend screening these cases as well?
So, Doc, with regards to these types of patients, so para kasi silang fall under asymptomatic carriers for COVID. So, this type of patients na may heart attack or stroke po. Now, this is also parang similar to those patients, for example, admitted for cellulitis. We have a clear focus of infection. But when we test for these patients, they tested positive. So this is where the importance of the standard precautions for COVID will enter, like the physical distancing, the appropriate use of your mask, as well as the frequent hand hygiene. So if we do these precautionary measures, then we are highly protected from these asymptomatic carriers po. So it will also really depend per hospital policies. Some because if we require all patients to be tested for PCR, then it would be an additional cost for the patient. At the same time, if in emergency cases, we cannot refuse naman po yung mga patients na may heart attack or na stroke just because they don't have the PCR results. So to be on the safe side, even if the patient has not been tested for COVID, we practice the standard precautionary measures po all the time.
Okay. There's a question from Dr. Tanangonan, our OB specialist. Hi, ma'am. Thank you for attending. I know that it is already recommended by POGS, that's a Philippine Obstetric Gynecological Society, that we do routine RT-PCR to all our pregnant patients once they reach 37 weeks, even if asymptomatic. In our setting, should we allow suit? Would there be any difference in terms of precaution if the tests are negative? Meaning they don't have to use the PPE. Let's ask the one who catches the baby together with their OB. So, Dr.
Yes,
Marky.
So with regards to the recommendation of the POGS po, so the value of the PCR po is only from the time that the patient is swabbed. So for example, if the patient was swabbed at 37 weeks pero hindi pa siya naman manganganak po, so for example, the next day after the swab, the patient was exposed to a COVID confirmed or asymptomatic. So hindi rin siya assurance that the patient is COVID-free until mag-38 weeks siya, mag-39 weeks siya. Now, I think there will be no difference po in terms of the precaution because as I have said po, we treat everyone as COVID positive. So we use our mask, we physical distancing, and then when we connect or when we try to manage our patient po, the precautionary measures po would still be the same. So kung for example, yung gown na ginagamit natin, yung mask natin, hand hygiene, and then physical distancing sa patient, they will not po differ. However, yun nga po, pag nag-PCR ka at 37 weeks lahat, paano kung manganak pa siya at 38 weeks? So the PCR po would lose its value po. So we don't change our PPE recommendations and the standard precautions po. Okay.
There's a question sent to me privately. Marky, I want to know your thoughts on this. We have a recent result of the lack of benefit of tocilizumab. I think this is from the study conducted by Roche. Does it still play a role in the treatment of COVID patients?
So based on certain studies, it has a benefit, and based from other studies, it doesn't have any benefit. So maybe if the patient is critically ill and other measures or other management po is not anymore working, like you've given dexamethasone, you've given remdesivir, and yet the patient is not improving, then personally po, I think we can still try tocilizumab based on a setting of a clinical trial. So kung ma-fulfill niya yung criteria ng clinical trial and then nakita nila na may benefit, then maybe we can still use this particular drug. Personally, in Pedia po, I haven't used any of the drug po, like your remdesivir and tocili, because in our setting po, Pedia po, majority of them po have only mild course po of the disease po.
Yeah, I think Roche gave out this advisory, and they did not actually specify the inclusion criteria in the study and what time during the course of the disease was Actemra given. So this is a preliminary result, so let's wait for further advice from WHO and CDC. Right now, we don't have any non-recommendation coming from WHO and the CDC, although it's not part of the Solidarity trial. It's still being given to some patients, given that it's an IL-6 inhibitor, so maybe it still has some value, especially if given during the time when the patient is in cytokine storm. Also, another doctor is asking for critically ill COVID patients with cytokine release syndrome, would you recommend hemoperfusion? I was thinking siguro dapat next webinar natin is we will call in our nephrologist to talk about hemoperfusion and our pulmonologist to talk about self-proning. No, But Marky, what's your experience on hemoperfusion?
Doc, honestly, Doc, I have no experience with hemoperfusion because I haven't or in pedia po, sobrang konti lang po talaga yung nagsisevere. So, I don't think that anyone from Laguna na pedia po has underwent
Yeah.
hemoperfusion. So, I really cannot answer po with regards to the question po.
From my experience, hemoperfusion is an expensive, somewhat effective way to manage cytokine storm syndrome. Giving tocilizumab is targeting only the interleukin 6. Doing hemoperfusion targets all other inflammatory markers, including IL-1 and IL-6. And hemoperfusion has a crucial role, which and a big help, which your steroids and your tocilizumab cannot provide. But still, out of the three, tocilizumab, dexamethasone, and hemoperfusion, only dexamethasone has data on good data on its efficacy against the cytokine storm. But I heard from another webinar that there will be results coming in regarding the RCT for hemoperfusion. So let's wait for those data. And maybe the doctor who asked that question can enlighten us on how hemoperfusion works for cytokine storm, right, Dr. Agoncillo? Anyway, that's the last of the questions in the chat box. If there are any other questions, we'll have another like 2-3 minutes before we end this webinar. Any questions from our frontliners? We have participants from the nursing, from from our respiratory therapists. Dr. Castellano is a part of the Employee Health Services Office of the RATM, and he handles those employees who would turn out positive to RT-PCR. So siya yung expert sa pag-clear ng aming mga COVID positive staff. Anyway, if there are no questions, you can visit Dr. Lodronio in radiology. I know Dr. Alonso frequents radiology during this time. And Dr. Mark Pasayan is our new pediatric infectious disease specialist. Good to have you on board in Cabrini, and welcome to Cabrini. With that, I'd like to pass on the microphone to Dr. Malen Gilido for some last words before we end this webinar.
All right. Thank you, the two Marks and Dr. Rico, Dr. Marky and Dr. Mark Pasayan, Dr. Lodronio, and everybody who attended and participated. I can see Dr. Cubin. Hello, Carlo. So, who attended this webinar or conference of sorts. So this is the first for Cabrini. We'll have more of this. Actually, I've scheduled twice a month. I don't know if that's doable. Maybe one conference lang a month. I try to follow the DOH calendar of di ba, daming piyesta piyesta ng colon cancer, piyesta ng breast cancer, these things, no? And so tuloy-tuloy lang tayo. We have a surge of these infections, and dumadami pa lalo dito sa Pilipinas nga, no? You see the epidemiology data presented by Dr. Castellano. Nakakaingit yung ibang Southeast Asian neighbors natin. Wala pang 1,000. Wala, tayo 100,000. So there. So iba yung pag-iingat lang talaga ang kailangan natin. And so there. And I'd like to end by announcing that Dr. Alonso, no, is still here. Maybe he's still here. I'd like to share that it's his birthday tomorrow. It's his birthday tomorrow, Dr. John Alonso. Happy birthday po. Thank you very much again, everyone. And we close this meeting. Thank you very much. Ingat po tayo. Thank you.
Thank you.
Thank you.